and this is the first one of this 2024. And we are delighted to have Dr. Wendy Chapman as our first speaker this year. Dr. Chapman is an elected member of the National Academy of Medicine, and she's currently Associate Dean of Digital Health and Informatics at the University of Melbourne, and the Director of the Center for Digital Transformation of Health. Previously, she was the chair of Department of Biomedical Informatics at the University of Utah. And then she has spent two decades developing and evaluating AI and natural language processing algorithms for healthcare settings. Her current passion is in designing, implementing, and validating digital innovations like AI and virtual care in healthcare. During her presentation, Dr. Chapman will discuss the role of an academic learning health system in connection with AI and other digital innovations to healthcare. We are delighted that Dr. Chapman is with us today and joining us all the way from Australia on a sunny summer morning, as she told us. And then we look forward to your talk. Wendy, the floor is yours. Thank you.
Thank you so much. Yeah, it's really a pleasure to be here and looking forward to sharing what's really going to be kind of a combination of what I see going on in the field, my personal experience, my philosophy of where we need to go to really leverage AI in healthcare, and the things that I've tried to do to contribute to that. All right. So I'll start with a story. This is Sasha Dublin. She's at Group Health in Seattle. And many years ago, I guess it would be in about 2010, she and I started collaborating. She was looking at patients that are treated with opioids. Do they get pneumonia more often than patients that aren't treated with opioids? So what she did is she collected chest X-ray reports for patients at Group Health. She hired two humans that spent 2 years reading these chest X-ray reports to classify the patients as they got pneumonia or they didn't get pneumonia. And only then, after the 2 years, could she do the research to answer the question. And so she wondered, could we have used natural language processing to classify those reports rather than that time-intensive, expensive feat of having humans do it. And so we worked together retrospectively to say, what if we had used NLP for that? How would it have worked out? And so we developed an NLP system that would output, I'm confident this patient has pneumonia, I'm confident this patient doesn't have pneumonia, or this report needs review because there's uncertainty for various reasons. And then we were able to show that we would have only had to review 10% of the notes, and there was high accuracy in those that were deemed confident by the NLP system. So that makes review of notes much more feasible to be able to do clinical research studies. So during my career in natural language processing, I worked on a variety of different types of applications of identifying patients for early screening, prediction of readmission to the hospital, quality report cards, and etc. So many different types of projects. And I did that. I started my career in Pittsburgh, where I spent 10 years as an assistant professor. I moved to San Diego after that. This is our Breakfast on the Beach series that we had. After that, I went back to Utah, where I graduated from, and became the chair of the same department, the Department of Biomedical Informatics, and picked up skiing again. And now I'm in beautiful Melbourne. This is the 12 Apostles, which is on the Great Ocean Road in Victoria. So along the way, though, I really got to the point where, all right, we've developed enough NLP tools. I really want to start implementing them in practice so that they do some good. That was my goal all along. And I encountered so many barriers to it. And questions that I started asking myself that I hadn't asked myself in the beginning as someone who was developing, the technology and the resources. Is this going to even fit? How would this fit into the workflow? Who's going to pay for it? Will it even make a difference? And so I had kind of an existential crisis, career crisis, and that's really led me to where I'm at now, where rather than developing the innovation, I wanted to develop the infrastructure that supports innovators in implementing them in healthcare. So I'm not alone in developing all kinds of tools that never have gotten to the point of care. Um, this is an article from last year in Australia about clinical AI and how in Australia, nearly all hospitals are clinical AI free zones. There are only 2 clinical AI stories in the whole country that could be found, and across a network of clinicians and a national AI working group called the Australian AI, I can't remember what it's called, but only one hospital has a trial of AI underway. So there are many barriers to implementing AI into healthcare. Now, the story in the US is better, in large part, but not only because it's been working on it longer. But I was a co-author on a National Academy of Medicine publication about AI in healthcare, and we listed the different user groups that can benefit from AI, the different types of AI tools that help them, and examples of applications that are being used. And so there are AI systems in place. An interesting case is the sepsis case, which most people know about from the failure part, about how Epic has a sepsis prediction model, and it's trained on a certain data set, and when it was ported to different locations, it performed very poorly. And that's a really important lesson for AI to learn. But people have worked on that and added local data and implemented sepsis prediction models across the world in 40 hospitals, and have shown that reductions in mortality. And that's a great story, but it's in contrast to the number of AI research papers. So 10,000 AI research papers estimated a year, and you can count on your hands and toes practically the number of AI tools that are being implemented in healthcare. Now that's going to increase, but what's going to make it increase? There's a lot of promise of AI, and people are really excited about it. Mayo is building a smart hospital and are investing billions of dollars to do that will focus on AI and virtual care. ASU is developing a new school of medicine and advanced medical engineering. But the question I think is important for all of us to ask ourselves is, even though there's a ton of great technology, and there is, why has there been so little translation? And for us as the audience, what role do we as a university play in improving that? So that's what my talk's going to focus on. If you think about the drug development process, there's a very clear pathway to getting a drug to market, and no one would ever develop a new drug in the lab and just put it into practice and try it on patients. There would be these processes that you go through, but in digital health innovation, and AI is part of that, there's a big gap in how to implement and evaluate them in real settings, and that's the space that I'm working in. Now, there are many frameworks to guide us in how to do this. In that Australian paper, he looked at 20 different frameworks that are out there for implementation of AI and created the Salient framework that really looks at all the different parts of the component development, the engagement of the organization, the policy domains that are important, and then the process that you really need to go through to get it ready for implementation and rollout. The learning health system is a powerful framework that many of us are using to learn from data that represents how practice is occurring, look for unwarranted variation, create new solutions, implement them to bring, to generate and deliver information to decision makers that improves their decision making, improves processes, capture data from that, and then start the cycle all over again. And at Wake Forest, the academic learning health system is a framework that has been developed that is a way to really look at how the goals of an academic medical center align with the learning health system and what role the university can play in that. And so in this talk, I really want to focus on 3 of the elements of the academic learning health system that I think are really relevant for implementation of AI into healthcare. And that's addressing social determinants of health, embedding academic expertise, and creating pipelines of experts and clinician scientists. So I really see AI applying to healthcare as a case of disciplined experimentation. There's so much we don't know about how to do it right, about what's going to work to have the human working with the machine in the decision making, and about local customization. So what we need is to have a lot of experiments going on, but they need to be really disciplined experiments that we're learning from, so that we can improve our ability to implement AI and generate evidence for its use. So there's 3 areas that I think are really important in that experiment to support that disciplined experimentation. And the first one is infrastructure for the experimentation. So in that Australian paper about the AI-free zone in Australia, he lays out the type of information technology infrastructure that's really important to support prospective artificial intelligence. And so you need prospective AI evaluation elements, and you need ways to extract data and so on. People are doing this at Mayo Clinic. A large group led by people at Mayo Clinic and Stanford especially have created a coalition for healthcare AI, and their focus is really standards and guidelines. How do we harmonize standards and reporting for health AI and educate people about how to evaluate them? So it's guidelines for the responsible use of AI in healthcare. The Mayo Clinic has an AI factory, and this is a really huge endeavor that they're doing to set up the infrastructure to really develop and test AI in a way that prepares it for implementation. And they have data sets and partners from all over the world in this AI factory. Their focus is really the supply chain. How do you get AI, into care? And they have a platform that's gathering data, where you're able to train and discover with your tool on large data sets, validate it, deliver it, and then work on the messaging of how that information from the AI tool goes out to the healthcare providers or other decision makers. At the University of Melbourne, we are also building infrastructure to support implementation of AI and other digital interventions. It's called the Digital Health Validitron. And our focus is on the implementability and the evidence generation of these tools. And so it has 3 parts. The first is a simulation lab, so that you can simulate clinical workflows where the AI is going to be embedded. To support that, we have a digital sandbox, which is a Smart on Fire enabled sandbox, so that you can spin out and replicate to the best of your ability the environment where that AI tool is going to be embedded. Whether it's going to pull data from an EMR, so it has EMRs, it has telehealth tools, messaging systems, remote monitoring systems, and it's growing in the number of things. So think of it as like a bunch of Lego bricks that you can now pull together to replicate that environment. So you have digitally enabled workflows. And then the pragmatic expertise of the researchers about how to run simulated trials to test out and validate the components of your solution, of which AI is only one piece. So in that, we're really creating a replicable set of processes to be able to answer questions like, what's a feasible payment model for this? What would a model of care built around this AI innovation look like? What are the regulatory frameworks you need? How do we integrate it into care and demonstrate that it's safe, and what outcomes are needed, and how does it scale? And asking those questions from the design phase and the exploration phase, rather than waiting until you have your tool built and then asking them and realizing you have the wrong answers or have been asking the wrong questions, which I have experienced that firsthand. In our simulation center, we have an outpatient clinic or a GP space. We have a hospital room and a patient home. And then we have these control rooms with one-way mirrors where you can see, in this case, you can see the patient home on the left and the GP office on the right, and they're having a telehealth visit. And we're working on how to integrate data from remote monitoring into the telehealth visit and use smart cards to send data from the EMR to the patient's phone so that they can take that information to their specialists. All right, so the infrastructure, I think the important part of it is really to help people realize that implementability of their tool is a core principle that needs to be considered at the outset of technology design and not be an afterthought. The next area then in disciplined experimentation is addressing disparities. And we all know that's crucially important for AI because we've seen how it can be harmful. Now, social determinants of health are a really important part of health for people. And, we know larger part than healthcare delivery itself. And and it's part of the quintuple aim of healthcare now. But in considering, the way tech is designed, validated, used, disseminated, and incorporated in healthcare affects the social determinants of health. So there's this relationship between the technology and social determinants of health. And so people have phrased a new thing called digital determinants of health. And those have been shown to be very predictive of success or failure of different types of healthcare interventions. And those are the factors that are intrinsic to the technology that impact the social determinants, such as the ease of use, whether the tool you've built is even useful for people. How do people interact with it? What's their digital literacy? Do they have access to internet and other digital things? The algorithmic bias that is introduced, personalizing it for people, data poverty and the information asymmetry between a patient and a clinician, for example. So these things all really affect whether your AI tool is going to succeed in healthcare and whether it's going to increase bias or decrease the digital divide. Because artificial intelligence really has the power to increase inequity, but it also has the power to decrease it. And we need to be really thoughtful about how we're applying it to be on the decrease side. So if we think about increasing inequity in the machine learning pipeline, at every phase, there are many decisions that are made by the developers that can increase inequity. For example, you just the problem you select to work on. We work on problems that affect white people and that affect richer people. The data collection. So convenience samples can exacerbate existing disparities in marginalized and underserved populations. The definition that we choose as our outcome can represent biased clinical knowledge and implicit power differentials and social disparities. Development of the algorithm, default processes like evaluating performance on large populations it doesn't work for subpopulations. And then once it's deployed, the lack of model documentation ignores shifts in population risks and patient safety. So all of these things are things we need to look out for as we're developing a machine learning model, a machine learning system, and also it's ways to ensure that we don't end up with extra bias. On the other hand, the AI can be used to increase equity. Oh, wait, I got the wrong thing. Okay, sorry. This is supposed to, oh, never mind. I'm still on that same topic. Okay. In addition to that, the data itself and porting the data to another place, and we need to pay attention to that. But those are not the only problems of increasing inequity, because the clinical utility of the AI models depends on how the providers use the outputs. And those the providers sit in a particular ecosystem, and they have particular processes and biases themselves. And so we really need to be testing our AI in our local environment over and over again. And this is from Nigam Shah, that I think is a really important lesson for us. It's not just a test once on a big retrospective data set and apply. It really matters how it's being used. Okay, now to the other hand, that AI can be used to decrease inequity as well. This is an example that I really liked called disparity dashboards. And it's a framework for systematically doing, equality improvement efforts. So you map data to variables beyond demographics to include underlying social or structural determinants of health and that have actionable information. And now you visualize that data and you can start to guide your QI efforts and measure and refine so that you reduce the outcome gaps that are coming. So AI can be really helpful in being able to identify disparities in groups. There are frameworks out there to help think about digital health equity, because there's many different domains of influence. And one of those domains is the digital environment, and that's a newer domain. And it affects the individual, the interpersonal, the community, and the social. And so this is a framework by folks at New York University, Langone. I don't know if it's Langone or Langone. They're my heroes, but I don't know what it is. And so we are using this in our Validitron framework to help innovators think about this throughout the process of the development of innovations. All right, so in addressing disparities, that same theme, that digital equity is a core principle that should be considered at the outset of technology design and not an afterthought. Then the third part is the embedded academic expertise. And to me, that's really a question of how do you build an ecosystem of partnership with the healthcare system. So back to the salient model, if you look at the types of expertise that's needed to really follow this model, it's very broad, and it's not just machine learning. It's change management, it's implementation science, it's data, it's service design, it's informatics, it's evaluation. So you need all kinds of expertise to really develop and implement and evaluate an AI model. An example of how this multidisciplinary collaboration can work is the Reimagine EHR program at the University of Utah. And this is something that we started when I was the chair there. And it's based on the idea that we know that the EHR can cause a lot of frustration and pain for clinicians. Well, imagine that you could create tools that help make the EHR a joy to work with. And so that's what it's based on. And a couple of AI tools that have been developed by the group is one that identifies individuals at risk for early onset familial cancers and offers personalized screening visits with an automated chatbot, and a diabetes pharmacotherapy outcome predictor that leverages big data analytics. So in the pharmacotherapy one, it uses a large data set to predict the medications that are most likely to be effective for an individual patient based on the goal that they have for their HbA1c. So it shows their goals and how they might reach their goals with different medications and the potential side effects that they would have and the costs, so that they can make more informed decisions with their clinicians. There are about 30 different apps that have been developed by the Reimagine EHR team, and the idea behind them is that they're built using standards, Smart on Fire standards, and so now you can implement them into different EMRs and scale them across sites. This requires a lot of different types of expertise. You can see the author list for the paper on this, which I'm right there in the middle, and many different types of people. The team has people with expertise in standards and interoperability, clinical informatics, security, user-centered design, machine learning, implementation, science evaluation. Well, building those teams sounds great. Team science, we know it's the way, but doing it is another story. So how do we build those effective partnerships when our incentives are often very misaligned? And on the clinical side, there's a lot of comments about, you don't understand us because you aren't a clinician, or research is not going to help us, you only care about getting your paper. And on the methodological side, people are really pressured to write papers and get grants on novel things. You don't get grants to maintain something or scale it or grow it in general. And getting publications is a really big driver. And so even if something is useless and will never be implemented, if you can get your publication, you'll keep working on it. So these are the kind of things that I've experienced, and I think happen everywhere around the world. So I wanted to share just kind of 3 things that I believe based on how to build effective partnerships across the academic clinical divide. So the first is that solving this problem of how we use the data, apply AI and other interventions, clinical decision support to healthcare, it's a completely unsolved problem. We've done the low-hanging fruit. Now we're into the complexity. Because there are so many different unanswered questions about how to do it right, then the typical linear models of change that we rely on, like the PDSA cycle, that has, you create policies and things. That's not going to do it. We need to marry ideas from complexity science and continuous improvement with proposals for creating a deep learning health system. There's a lot that we need: the scientific method, we need research. All right, the second point is that we need technology, but the technology is just not the point. And it's we need, the clinicians, administrators, and methodologists have to be working together from the beginning. And we know that's true because, like I said, the 10,000 AI manuscripts a year, there's hundreds of thousands of health apps that many of them are never used and implemented in real settings. So if it was only technology, it would all be implemented and we'd all be really happy because the technology is largely there. It's how do we make it usable in healthcare. And third, healthcare is an information business. So, these new medical schools, and they're focusing on engineering, which is great. And they're focusing on, we want to have our medical students use all the great tools, virtual reality and AI. And I love that. But I want them to pay attention to the fact that healthcare is an information business. Those tools are ways to bring information to the table to improve decision-making and processes. And Chuck Friedman's theorem of informatics is that the human plus the computer is greater than the human. And we all know that the unaided mind cannot manage the amount of information in healthcare today. So what does that mean for artificial intelligence? That you're going to be building tools and implementing them. And now that output from that AI tool is one piece of information among many that clinician is going to use to be making decisions. So what we need to be working on, training people about how to use that information. How do they merge that with the data that they already have? They need to understand probabilistic reasoning. They need to understand how to incorporate it into decision making. And that is a skill that our medical students and our clinicians and we as humans are pretty bad at. So I want to talk about a few ways that we here at the University of Melbourne have been trying to I would say my goal at the University of Melbourne has largely been to become good partners to the healthcare system. Because the University of Melbourne has not been at the table in the past. They have not invested in this space, and they decided that was, they needed to change that. So they invested in this new center that I lead, and it was called the Center for Clinical and Public Health Informatics. And I changed it to the Center for Digital Transformation of Health because I really wanted it to be about what we're trying to do. And the informatics is one piece of the puzzle, but it's only one piece of the puzzle. So our center is very multidisciplinary. Okay, so we've been doing 4 things, I think, to become partners of value to the healthcare system and to build capacity. The first is workforce training. And we're just it's early days for us, so these are the things that we've started and we will grow them. But we have an applied learning health system course that is a really interactive course where you live out a case study. And the case study is that you work at Mount Superior Hospital and you realize that there are too many hospital admissions for people with diabetes and our waiting lists are too long for our specialists. So how are we going to reduce that? So we create a learning community, a simulated learning community, and we step through the learning health system framework. We use real data. We identify predictors for hospitalization through machine learning. We design a solution, co-design a solution with patients. We develop the back end of an app and we plan our implementation and evaluation. So they get to step through all the phases in a shallow way, but enough that they realize the complexity, and they have a toolkit to lead with and a language. So our hospitals in our region send groups of people every time it's offered, which is twice a year. And we train about 100 people every time we teach it. And it's been really fabulous. That's reaching the broader group, but there's a need to have clinician collaborators in the health services. And it's very different here in Australia. There aren't clinician scientists as there are in the US, where and there are very few people doing research in digital health, applying digital health to healthcare. And so we have developed something called the Learning Health System Academy to try to grow the capacity of the health care organizations, including general practice, but mostly hospitals, to equip and grow future leaders of digital health research. And so we've trained 2 cohorts of 25 people total, and we're just starting our 3rd. And each hospital chooses one person that they want to grow, 1 or 2, and they spend a year with us, 2 days a week, working on a project that they select that's important to the hospital. And then those projects are growing, and now we're starting to apply for grants with these. We've grown our collaborators. Then embedding research, that's really important. And I grew up and was trained in that model because I was trained at the University of Utah. The department was formed in 1964. It was a collaboration with Intermountain Healthcare, at the time LDS Hospital. My office was in the basement of LDS Hospital, and my supervisor, Peter Haug, was a leader of informatics there that was really implementing decision support, and people were embedded in areas. Scott Evans, who did the antibiotic assistant, was embedded in critical care, and he spent his whole career working with them. And there are different models of embedding, I think. But so how do we do that in a place where, in like Melbourne and Australia, where they do not have academic health systems? We have about 9 hospitals that we're affiliated with, and trying to, how do we build the collaborations where we can be embedded with them? So our first toe in the water is Royal Melbourne Hospital has developed a digital coordination center to improve flow and decrease ambulance ramping and all those things that we're all suffering from. So we have an epidemiologist embedded that's helping and a qualitative researcher, and we have a logic model of what, and on the right side is what they're trying to accomplish. They're trying to increase, use real-time data to manage patient flow and so on. But we wanted them to think more upstream about how the particular activities like integrating data, monitoring the data, creating escalations, and how those things are going to lead to those longer term outcomes, and knowing that the implementation of them can make or break it. So let's look at it from the very beginning as you're implementing it, so that we can learn and pivot and make changes to be more likely to get to those longer term outcomes. So the epidemiologist is looking at the data and the data flow, and are they getting the right data at the right time in the right form? And the qualitative researcher is looking at the workforce. Are you communicating in the right way? Is this fusion team that we've created working, and interviewing people? And so that's been a really nice project to start to work together, gain trust, and show them how embedding this type of academic expertise can help them with their practical goals. And we hope it will grow. Then the last thing is really like systems of partnership. And this is a really important lesson, I think, that if we want to make large scale change, just creating a whole bunch of small scale repeated change is not going to get us the large scale change necessarily. We need system-wide frameworks to support innovation. And that means we need different types of leadership and governance in our healthcare organizations to implement innovation. So an example from my personal experience is when I went to the University of Utah to become the chair, our past at the University of Utah program has been with Intermountain Healthcare, but there was and is a big rift with Intermountain Healthcare, and we were really focusing at that time then on the University of Utah healthcare system. We were not embedded at all or involved at all in even the data warehouse, the CTSA, the clinical informatics, any of that at the University of Utah. Our department, even though it's like strong in the world, is like on the side. So it was my goal to try to integrate us better. The way I thought I would try that is, let's have some seed funding. And we spent a year where informatics researchers met with hospital staff of various different people to come up with joint projects, and we seeded funding for those projects, and we built some partnerships. In the end, none of those projects got implemented, and not a single grant came from that seed funding. So that wasn't a good way of embedding expertise. So the next thing we did was the Reimagine EHR, which I described. And that was really built on that you have to have a team that's embedded in the healthcare system. And so Ken Kawamoto leads a team called Knowledge Management and Mobilization. And we really focused that team on the Reimagine EHR effort of developing apps for the EHR. But it's led by the CMIO and the CIO. Ken's the associate CMIO. The chair of the department is involved in the steering of it. The director of clinical information systems, nursing informatics, chief technology officer. So it's really, the structure and governance of it is really aligned with what the healthcare system needs. And then because we as researchers are part of that embedding, then they're applying for grants that are easier to get, because now you have a healthcare system where you can implement and evaluate your application, and B, you're able to bring new money into the efforts to help the healthcare system improve from that grant money of things that you wouldn't work on because the operational funding only covers a small portion of it. So it's really a win-win situation. And I think there are many examples of that. I told you NYU, Lanzhou is I really look to them as models. They have something called Future Practice. And this is this is an innovation lab within the medical center IT group, where they explore, design, and test potential healthcare solutions in their system. And they have a research group on the side that works with them, like the Reimagine EHR. And so it's very embedded with research and practice. In Australia, Sydney Children's Hospital is really working on an embedded learning health system unit. And this is similarly trying to, develop the information infrastructure, data infrastructure, to start asking questions about how to innovate in their hospital. Okay, so I just think AI just won't reach its potential if we don't have new leadership and governance in our healthcare systems. And I think every innovator feels this in their gut, because they develop something, it's accurate, but how do you get it in the healthcare system? You hit all kinds of blockades. We have to be able to connect the bottom-up innovation that's going on from the clinicians and from the researchers with the top-down strategies, and there's a huge gap between them. And that gap requires people, processes, and technology, and they need to be at the system level. So three thoughts for me about that, the types of system models that we need. First, the middle, the meso level is underdeveloped, and that's where we see the gaps. Everyone has a digital strategy. That's at the micro. You got people at the coalface who are innovating, but it's connecting those two. And when that middle level is missing, then organizations have a really difficult time implementing initiatives for innovation. And what you get instead is silos and hero projects and ad hoc processes, which we all see. Second, the current workforce that we have just doesn't have the needed knowledge and skills. And that workforce, from the bottom to the top, needs more understanding of the technical factors and the digital determinants of health, and how machine learning works, and how decision making works, and how what helps implementation fail or succeed. Those are all knowledge. That's all knowledge that everybody needs to have more of. And then third, innovation cannot live in business as usual. So you need people who are immersed in innovation, but aligned with business as usual. Because otherwise, if you assign innovation to the business as usual team, they're always going to have fires to put out and dedicate their attention to their everyday work. And Gartner calls this the bimodal practice of managing two separate but coherent styles of work. One focused on the predictable, which is the business as usual, and the other on the exploration, and they have to work together. So I think it's really more like we need a guiding principle. We need to stop trying to design the solutions and instead design for the conditions that enable the emergence of the solutions. And I think the learning health system gives us that opportunity. Okay, so in conclusion, I'm going to tell another story. And this is a story of the rise of informatics and Homer Warner, who was the founding chair of my department at the University of Utah. So in 1959, the first paper was published on reasoning with data for medical diagnosis by Ledley and Lusted, that you could use symbolic logic, probabilities, and value theory to reason. This was a theoretical paper. It laid out the conceptual idea. And Homer Warner was very excited about this idea, and he implemented the idea in a 1961 paper of a mathematical approach to medical diagnosis and applying that to congenital heart disease. This is the first paper where it used real data, real patient data, and compared the computer against the physician to see how it worked. And I listened to a great book, The Theory That Would Not Die, about Bayes' rule. And they mentioned Homer Warner in it. And at the Latter-day Saint Hospital in the University of Utah, he developed in 1961 the first computerized program for diagnosing disease. And he showed that Bayes could identify their underlying problems quite accurately. Old cardiologists just couldn't believe that a computer could do something better than a human. This is in 1961. I think people are finally starting to believe that. But these were seminal articles, and they led to the development of what's now called biomedical informatics or health informatics. And these are a citation graph that shows how the field grew out of these two articles. So biomedical informatics has been working on data-informed decision-making since the 1960s. There's a lot to learn about that, and Homer learned some things early on. First, he built systems to collect and display data. He built EMR and EMR, the health system that was installed, and he built tools in the ICU to collect data. And one of the programs that he built was flashing yellow, and the nurse was looking at it, and he came up to the nurse, and the data was all there, but she was very confused about what it meant. And so he sat down with her, and they worked through together what it meant, and then made a decision about the patient. And that was a turning point for him, because he realized that it's not just about getting more data. You have to add intelligence into the system in order to help people know what that data means and how it can be applied in the decision making. So that call for intelligence. All right, so I would say AI is not new, but it's never had more promise. And of course, there's so much excitement about it, which is great. We can learn from the past 70 years of people trying to implement AI and mostly failing. IBM didn't learn from the past, and they made mistakes that everyone had already made, and they didn't learn from that, and they failed. And I think that's one of the main reasons. So how do we learn about what works and what doesn't? I think that's a really important part, and understanding, and it's a very multidisciplinary question. It's not just informatics. It's not just AI. The academic learning health system provides guides about how we can contribute through embedded expertise, through training people and growing capacity, and by helping pay attention to how algorithms can increase or decrease the inequity. We need to think about the core principles at the outset of the technology design and not as afterthoughts, and that involves having infrastructure to help people do that. I and others creating our algorithms off in our office we are not going to be able to think about those things in the way we need to. We need to have infrastructure to help us. We need to have partners that are helping us think about not only the clinical side, because we all have clinical partners when we build our tools, but we don't have partners that are helping us think about how it's going to be used and implemented, and the security and all of those types of things. And how do we really build true partnerships? So this is just my chicken scratch of what I'm trying to put it all together in my mind of how it all fits. If you've got it involves clinical care, it involves research, and it involves education, and they all have to work together. You've got your strategic goals on the clinical side. You've got individual research projects down at the bottom, and we need to have that infrastructure to support them where you're paying attention to the selection of what you're working on much more closely. The way I chose what to work on, I just, if someone was interested, that's what we worked on. And we work on what we get funded for, right? But what's really going to have impact, what's feasible, we need to think more about that from the beginning. And we need to there's clinical research and data infrastructure already in place. You guys are a great example of that, so much with the CTSA that you have in place. But we need other tools to help the innovation. Frameworks, data models, sandboxes, simulation labs, to really help go from the design to the validation to the pilot to the scale, so that we're really generating evidence for what we do. And along the way, we need to be training people at every phase of the types of things that they need to understand, so that we can be true partners. So I'll close with black swans. Everyone says, oh, that's like a black swan. Well, in Melbourne, they only have black swans. If I saw a white swan, it would be very unusual. It'd be the anomaly. And this is the dog beach, actually, where my dogs like to swim. Thank you, and I look forward to your questions.
Thank you very much, Wendy. We're all clapping for you.
Yay! And I see Angela. Hello.
Thank you for this wonderful presentation. You put artificial intelligence, informatics, and academic learning health system within the same framework. That is wonderful. It's music to our ears. We have time for some questions, and then please raise your hand if you want to ask a question. And then I see that Kevin has his hand up first. So Kevin.
Thanks, Minton. Wendy, that was fabulous. Really, really a great talk. Thank you so much. And I think you brought together a lot of the concepts that we've been essentially working on and trying to coalesce into a story for at least 2 iterations of a CTSA grant, and certainly since we integrated with Atrium and now Advocate Health. So I think, a picture's worth 1,000 words, and so many of your pictures are really on target. In fact, I just texted Christy. Your last figure there is very close to one we just discussed in our executive committee for the learning health system, and how we're going to look at, vet, and develop projects in this interface. So it's really, really good to see. I think you had a couple of really good examples of how well this worked in different areas. And I guess I'm thinking mostly of the Latter-day Saints one in Intermountain. And then what made it fall apart? What were the things that it just couldn't be sustained? And now there's this flip to Utah. Why hasn't Kaiser been able to move their product outside of California and be very successful? What are the things that are getting in the way of that? Is it misaligned incentives because of U.S. healthcare and how difficult that is? Have you found it's better in Australia because of the alignment of prevention and treatment, and the government is the one that benefits from saving costs all across the way, not different segments? What is it that you think would make this sustainable?
Oh, you asked the hardest question first, Kevin.
Sorry.
And I wish I had more insight into the Intermountain story. There are lots of things you could be referring to. Why did they not keep the help system? Why did they go to Cerner, and now they're switching to Epic they've spent decades switching. They did GE, and they spent 10 years on that and then scrapped it. And then they went to Cerner, and now they're scrapping and going to Epic. And I think from an informatics reflection there, these homegrown tools that used to rule the US and now are all gone, they didn't pay attention to the money. They didn't pay attention to the administration and the billing, because we're researchers and we care about clinical decision making. I think that's one of the reasons. I'm sure there's many others, but in terms of the relationship between the University of Utah and Intermountain Healthcare, that was complex, and I just watched it. I came in the middle of it, but it was I think some bad decisions by some leaders about, well, that's not fair that they get the same privileges as we do at the university at Intermountain Healthcare as faculty, and putting restrictions on that, and that really made them mad. But then there's also, I saw Intermountain Healthcare, and I'm an outsider to Intermountain Healthcare, so this is all just my outside observations. They brought in, they just shook everything up and created new structures that were based on business models, but not the tried and true things about how you really innovate in healthcare. For example, the programmers are all one giant pool of people. And when you need a programmer, you make a request and they hand you one. But that goes against the whole embedding idea of before you had, these programmers that were in critical care or cardiology for 20 years, and they understand the data and the flow and the patient flow in and out. And now you just get this random person and you're throwing them, and they don't understand the data. That flopped and they scrapped that. So I think there are many lessons, and as an outsider, those are just a few things.
Thanks.
Yeah.
Gary?
Wendy, I just want to echo Kevin's sentiments. That was, absolutely wonderful, presentation. And I think you hit on a number of areas that, we're actively, working, to, figure out what that mousetrap, really looks like. Maybe let me just pick, one small piece. So health systems are getting bombarded with potential AI solutions for every single, problem, they have. You highlighted, in your opening comments, some of the issues that arose with the epic sepsis model. So a tool of, potentially great impact that could help hospitals identify, patients who are, likely to have adverse outcomes, from sepsis, much earlier in the course, and, recognize how sick these patients, really are, before perhaps it came to clinical attention. If you implement the wrong decision, tool, it could have huge consequences for misallocation of, resources and adversely affect outcomes. What would, how should a health system approach AI? What would, an infrastructure look like, to make sure that a health system is putting the right, tools in place? What would you see the role of, the academic learning health system in this?
Yeah. Well, another hard one, big one. I think that the AI factory that they're developing at Mayo is really thinking through how the development of the tools on different data sets and the, testing its algorithmic bias before you're implementing it. So I think you have to have tools that are helping on the development side. And then you have to, from the beginning, I think, be thinking about how it's going to be implemented. What's the output going to be? And how is that output going to be used by the clinicians? Because oftentimes we'll develop, I love this paper by Karen Verspoor, who's here in Melbourne, about NLP being thought of as a classifier. And you're spitting out one thing, yes or no. Yeah, they have sepsis, or they're at risk for sepsis, or they're not, or maybe it's a probability. But that number is really hard to integrate with the other types of information that the clinician knows. So maybe another approach is looking at just all the variables that you're feeding into that AI to get that one decision, making those variables visible. And now they're able to integrate that information. So I just think there's many ways to present the information to the clinician. And then there's, when do you present it to them? Do you present it to them before they make their decision, after they make their decision? And there's been conflicting research on that in radiology about when it helps. So it probably depends. So all these questions, I think, have to be simulated and tested before you're putting it into the real setting. I think that's a key part. And then when you do put it in, I think there needs to be, the piloting in small ways and growing it. And then you have to have all kinds of surveillance on it to be looking for data shifts and other types of things. It's just it's a lot of resources, I think. And if we think about the resources it takes to get a drug to market, we don't accept all of them, but we know it's a huge amount of resources. But many of us think AI, or you just get a student, you build a tool and you plop it in. No, it's going to take a lot more.
Thanks.
Any other questions? Nick?
So Wendy, just to follow up on that, where do you start? Because I imagine if I went to Kevin right now and said, okay, I'm going to need multiple millions to build this vision, the answer to that will be a hard no, right?
Yeah.
And so I'm curious.
Not for you, Nick. It's a hard yeah.
But it's a very big problem. And I don't think we can just say, well, we're going to build a whole new solution. And so I'm trying to think, where's the incremental steps? in this process where you can try to make process. And so I think a concrete question would be like your simulation lab. Who pays for that? Like, how is that actually funded? Because I think that's the type of thing that we have to think about, and how we build this thing incrementally.
Yeah, excellent question. So one thing I think about where to start, I think that there needs to be like a learning health unit. There needs to be a group in the hospital that's co-funded by the hospital and the university that is making decisions about the types of AI projects to look at, that creates processes for that. So you're bringing everyone to the table, like the future practice and like the learning health unit at Sydney. And when you have that in place, now you have and you guys already have pieces of this. You have infrastructure to support that, and education. So what we've learned, like even with the Validatron, many researchers, they're so far from being able to leverage it, because they're even back at, they come to us and they say, oh, we need an app. Can you be the team to build our app? And when you dig back to what's the problem you're trying to solve, maybe an app's not even the right solution, maybe AI is not the right solution. So I think like this pipeline where people are coming through, but you're helping them think earlier about what it means, what they're really trying to solve. And a lot of those people are gonna, it's less of a filter as a helping the good ideas move along and the bad ones fall apart. And so it's not people, it's really the ideas. So I think I think you can do that with less investment, and you start to grow the infrastructure as it's needed. You don't have to build everything up front. And yeah, that's what I'm thinking. But but I think it has to be a joint thing with the healthcare system and academics.
Even if you can keep it really fast, please. We are approaching the top of the hour. Thank you.
Sure, absolutely. I mean, I think, Nick, the answer to your question, and Wendy, your answer is absolutely right. It has to be jointly funded. But the question I have for Wendy is, what's the role of scale in this? How much can we learn from the system itself and its running, and be able to leverage that scale?
Yeah, I don't have a lot of experience with that. I look to you guys for guidance on that. I know that's a harder question, I think. But the one thing I would say is you have to be thinking about that from the beginning, about the scale and how things might scale or not. But I don't know I don't know the how, because I haven't been involved in such a big system to
Yeah,
have
I'm actually
experience.
thinking back the other way. How do you take the lessons from scale without having to relearn them? But for example, your equity issues, right? I mean, we ought to not look necessarily at whether an outcome is the same in African Americans as Caucasians, as much as does that intervention help both African Americans and whites, and what's the right comparator group, and do we have a different comparator group because we have scale, that we can look at your social determinants of health and really utilize the scale to inform that question much better. I think that's what we have an advantage of in Advocate Health. We third largest not-for-profit health system in the country.
Yeah, that makes complete sense. Yep. And I think that's what the AI factory at Mayo is trying to go for, is that scale of the data as well, so that you can really test your tools on different populations that you may not have. But yeah, I think that's great. I'll take that as a concluding comment.
We really like that. We will continue this Artificial Intelligence in Action seminar series. So next month, actually, we are going to talk about health equity. And then if you're interested in health equity and AI, we have an amazing speaker. If you are not a member of our Center for Artificial Intelligence Research, please become a member so that you will be aware of all of our activities. We have amazing activities coming up. And let's thank our speaker, Dr. Wendy Chapman, once again for her excellent presentation.
Thank you so much for the opportunity.
Can they reach out to you with questions if they have other questions?
Yes, if there's anyone that wants to meet over Zoom and talk, I'd love to. they offered me to do that now, and I knew it's the end of your day, and before the meeting, it was the beginning of my day, so we can schedule a time.
Yes. So thank you. We appreciate that.
Yeah.
Have a
Thank
nice
you.
evening, everybody. And have a nice day for you, Wendy.
Thank
Enjoy
you.
your
Yeah.
nice summer day.
Thanks. See ya. Bye.
Bye-bye. Bye-bye.